right. Hello, everyone. Welcome back for another episode of some continuing education. Today, we're going to be talking about psychiatric emergencies. I know this is no surprise to anyone, but psychiatric emergencies are a very large problem in the state of New Mexico. We're actually in the top 5 in the country for prevalence of mental illness with limited access to care. This is based on some findings from the CDC. And if you look at that, that actually is reflected in our EMS call volume. Since there's not a lot of places for these patients to go seek care, they tend to call 911 and find their care in the emergency department. And so over the years, our volumes have increased in terms of psychiatric responses. In fact, almost 20% of our EMS calls are related to psych or substance abuse related issues. This is also reflected through the State Department of Health and the suicide rates for New Mexico. If you see the chart here, the blue line is the national average for suicide deaths per 100,000 population, and our population is almost twice that in terms of the people that are dying from suicide every year. Not only that, but the statistics are the same for youth suicide, and concerningly, over the last couple of years, since 2017, there's been a very large spike in youth suicide in our state. Not only suicides, but drug overdoses are a problem as well. Again, we're almost twice the national average for drug overdose deaths and substance abuse. So a psychiatric emergency is defined when abnormal behavior is threatening a person's health or safety or the health or safety of others. So it's not bad to be a little bit crazy, but when it's affecting people's own personal safety or the safety of others, then it becomes an issue for us. And realizing that a lot of psychiatric emergencies can be medical, they're not always just psychiatric or substance related. So it's important for us to try to stay objective and rule out the medical causes first. I like to keep things simple and just do lists of 5. So if we're talking about altered mental status, there's 5 causes of altered mental status. Number 1 would be vital signs. If someone's super hypertensive, they might have a hypertensive crisis or a stroke that's causing altered mental status. Toxic or metabolic can be something as simple as an ingestion or low glucose levels. Obviously, something structural in the brain or even the heart or lungs can cause changes in a person's mentation, whether they're hypoxic or they have a concussion or they have an infection. All of those things can cause a change in the way a person interacts with their environment. And after you've ruled out all of those 4 things, vital signs, toxic, metabolic, structural, infectious, then we can start to think about maybe this is just purely a psychiatric problem. We need to be responsible, be considerate, and consider medical causes of these mental health emergencies first. So that said, this is a talk about psychiatric emergencies, so the rest of the talk will focus on mental health. So as we mentioned before, we do have high rates of depression, high rates of suicide, and substance abuse in this state, and these are very frequent causes of calls to EMS. They're asking for help typically, and we need to be able and ready to help when they need us. One of the more frequent calls is depression and suicidal thoughts or actions. We respond to these scenes a lot, and it's important to recognize risk factors for actually completing suicide. So one of the most important questions you can ask when you're gathering your history is if the person has had a previous attempt at suicide. If they answer yes to that question, realize that they're 40 times more likely to complete a suicidal gesture if they've had a previous attempt. Other things, and these are cumulative, so if you have more than one, your risk is even higher, but relationship problems, financial problems, mental health problems, history of depression, history of bullying, previous substance abuse, or physical disability or illness are all risk factors for suicide. If you look at the trends, again, youth suicide continues to increase and is currently under a lot of investigation by a lot of national agencies as to why. This was a recent article in the New England Journal of Medicine, again, just highlighting the trends in youth suicide, which have almost doubled from 2007 to 2015. There's a lot of talk about exposure to social media. Some interesting studies are coming out, especially with young girls and their depression related to social media use. Suicide is the second leading cause of death in 18 to 25-year-olds. So if you have a young person you're called to the scene that's talking about suicide, take that seriously, knowing that it is an increasing trend and they are at increasing risk. And they have the same risk factors as adults do. So substance abuse, history of depression, engaging in risky behaviors, maybe not doing well in school, negative view of self, isolation, feeling alone, relationship difficulties. Sometimes you'll see patients that have performed some self-harm. This is thought to be a coping mechanism that helps distract people from negative emotions or to release tension in an effort to just be able to feel something. Usually it's a consequence of some emotional suffering that's kind of worked itself to the surface. And then we have intentional overdoses as well. We'll talk about that in depth in another discussion, but if you are on the scene of an overdose, it's very important to gather what substance was taken, the number of pills if you can, the dosage, and the time, and realize that you're the person there on the scene with more information than anyone else is going to have. So collect as many clues as you can to what the patient took, and don't be afraid to call the poison center if you need to. Psychosis is another type of mental health emergency. We mentioned before that it's not illegal to be a little crazy, but it becomes a problem when the patient's a danger to themselves or to others. So frequently this will manifest as someone who's just completely out of touch with reality, maybe very disorganized in their thoughts, or delusional and paranoid. Excited delirium is another mental health emergency that's usually associated with stimulant use, typically methamphetamine or spice or cocaine, and this can truly be a psychiatric emergency that leads to medical emergency. These patients are at very high risk for cardiovascular collapse just based on the incredible adrenergic stimulation that's happening in their body. You can usually recognize these patients based on the substance use history, but also by an incredible tolerance to pain, superhuman strength, and usually these aren't patients you can even wrestle down to get vital signs on, but they'll be incredibly tachycardic, very sweaty, and incredibly strong and agitated. Okay, so now you know some of the common psychiatric emergencies that you'll be called to. What should you do? I know this is frequently a gray area for EMS providers and a source of a lot of INSEP calls for the physicians in the consortium. Now, if the patient is asking for help and voluntarily wants to go to the hospital, if you've ruled out all the other causes of altered mental status and it's pretty straightforward depression or suicidal thoughts, that patient can actually be transported by the police department if they don't have another associated medical complaint. As long as their vital signs are normal and they aren't currently intoxicated or have overdosed on anything, those patients can go directly to the psychiatric emergency department. Now, these patients do have some gray areas sometimes, whether they technically are a threat to themselves or others, or whether if they don't want to go to the hospital, if we can just let them stay where they are. If you're not really sure, sometimes during peak hours, there are mobile crisis teams available through police dispatch. So if you have police on scene with you, you can request these teams through their dispatch process, and they can come to low acuity psychiatric calls. And what I think is a great thing about these teams is they actually bring a mental health provider with them to the scene. So it saves the patient a trip to the hospital. They get the care that they need, and they also have police there with them, so it's safe, and it's an on-site behavioral evaluation, so it's good for the patient, it's good for the system. Don't be afraid to get them to the scene to come and help you out. In terms of which patients we can force to go to the hospital and which ones we can't, this is what the law says. So it's a good faith judgment by the provider on scene, which is you, that the patient cannot make an informed decision about what's going on and is likely to suffer disability or death. So what you're looking for is some sort of life threat that the patient doesn't have the ability to understand the consequences of refusing, and that is all just based on your good faith. And if you look at how the EMS Bureau interprets that, it's pretty much the same thing. A patient who is mentally incapable of making decisions, whether that's due to their current mental status or substance abuse or whatever, who's displaying inappropriate behavior and cannot respond to questions. And the Bureau actually involves suicidal patients as well. So this is the first place in the legislation where you see suicidal patients can fall under the realm of forced transport. So really it kind of comes down to whether or not your patient is able to make an informed decision. And the way I like to test for this is if they can explain back to me everything I just told them about why this situation is risky, and they can verbalize back what their risks are and the fact that they're willing to understand and accept those risks. Part of the gray area comes in when you have kind of the he said, she said situation with maybe a depressed patient, or in the midst of an argument, there's a threat of suicide. Was that really a suicide threat? Did they really mean it? He said, she said it, but we're not really sure. If there's no real evidence, it gets kind of gray and it's difficult to tell. Really, it's up to the provider on scene to kind of weigh the risk in this situation, and this is frequently where we'll get called through the consortium for help kind of sorting through the situation. What I would do is just have a good memory of those risk factors that we talked about earlier. So if you have a patient with a pretty severe history of depression and a previous attempt at suicide who clearly is having relational problems now and maybe financial problems, that's a patient that's pretty high risk. And if there's someone who's saying that they threaten suicide, even if they're denying it now, I have a low risk to send that patient to the hospital or call the MCT team to the scene to actually get a behavioral health assessment for that patient, realizing that their risk is pretty high. Feel free to call consortium if you need to. I know these situations can be pretty difficult and hard to navigate. For patients that you do decide to leave on scene that you don't think are super high risk but still might need some help, there is a statewide crisis action hotline through Bernalillo County, and it's staffed 24/7, and there is English and Spanish capable interpreters, so it's a pretty nice resource funded by the state of New Mexico. Here's the number if you need it. It's 1-855-NM-CRISIS, and they are 24/7, 365. When we talk about forced transports, I touched on this a little earlier, but what do you do with a patient that you think needs to go and they don't want to go? It really comes down to, do they have the capacity to understand? It takes a court and a lawyer and a judge to determine a patient's competence. That's something that is ongoing and is declared through legal means. Capacity is something that can change with time and circumstances, and that's what we are judging in the pre-hospital setting. And really, it's just, how is this patient's ability to understand the current circumstances right now? Can they verbalize the risks back to me and truly understand what's going on with them and be able to accept the consequences of their decision? When we're talking about pediatric population, they don't need parental consent for any drug or alcohol abuse related call. If there's any concern for sexually transmitted diseases or possible pregnancy or psychiatric care, parents do not necessarily have to be consented for that child to go to the hospital. Other ones that don't require parental involvement would be emancipated minors. That would be a patient who's maybe 16 years old and already married, anyone who's active duty military less than 18, a pregnant patient, or has been legally emancipated. Now that said, anyone who doesn't fall into those categories and you have a pediatric patient that you're concerned about, parents can make decisions for their children, but they can't make bad decisions. So again, this is where you can call consortium if you need to. It gets into a little bit of gray areas, but if you feel that this parent is not making a decision in the best interest of the child, you do have the ability to take that child to the hospital for further evaluation. So the bottom line is the questions you should ask yourself. I try to keep it simple. Do you see a life threat? If you leave them, are you worried they're going to die? Can this patient truly understand the risks, and are they a risk to themselves or others? If you truly, in good faith, don't think they can understand the risks and they truly are a risk to themselves or others, that's a patient that needs to go to the hospital. Just remember to keep yourself safe first. If you need to, if you're moving towards physical restraints, just realize that's temporary until you can get the chemical restraints on board. primary thing is to keep yourself and other providers safe and then facilitate care of the patient. Agitated delirium is a relatively rare instance, but it's something to be aware of and recognize. If you see that patient with superhuman strength that's incredibly agitated, realize that they are medically at risk for that cardiovascular collapse, and this is a patient that's going to need ketamine. Now, right now, Albuquerque Ambulance is the only service in the city that's carrying ketamine, but you can still recognize these patients and help facilitate this drug administration when you see a patient that needs it. Vital signs are vital, so once you do have a cooperative or calm or sedated patients, you want to continue to monitor vital signs. If they are continuing to be tachycardic or hypotensive, they might need fluid boluses. Keep them cool, and make sure you're monitoring end-tidal on any patient that you've sedated in order to protect their airway. Overall, I know this is a big gray area with psychiatric emergencies, but if you're acting in the best interest of the patient and trying to do the right thing, I think your actions will be defensible 100% of the time. If you have any questions, let me know. I'll be happy to talk, and I know the 7/8 will too.